The study I will discuss in the next few minutes reports data on the use of Glofitamab in patients with relapsed refractory mantle cell lymphoma, and has been recently presented at the ASH meeting by Tyson Phillips. Mantle cell lymphoma is an aggressive subtype of B-cell non-Hodgkin lymphoma. Patients with relapsed refractory mantle cell lymphoma have a poor prognosis, particularly when they progress after therapy with BTKi inhibitors. Glofitamab is a T-cell engaging bispecific antibody with a novel 2-to-1 molecular configuration characterized by 2 binding sites for CD20 and 1 binding site for CD3. As has been reported earlier this year in a paper published in the Journal of Clinical Oncology, Glofitamab with Obinutuzumab pretreatment has a promising efficacy and manageable safety in patients with heavily pretreated relapsed refractory B-cell non-Hodgkin lymphoma. In this study, it is clearly shown that Obinutuzumab pretreatment at 1,000 milligram and or step-up dosing at cycle 1 have a clinically significant mitigation of cytokine release syndrome. Here, in this specific study, we got preliminary data from the NP30179 phase 1/2 trial in patients with relapsed refractory mantle cell lymphoma who received a 1,000 milligram or 2,000 milligrams dose of Obinutuzumab prior to Glofitamab monotherapy. Based on PK findings regarding the clearance of Obinutuzumab, we expect that a higher dose of Obino prior to Glofitamab step-up dosing could further reduce the risk of CRS in mantle cell lymphoma. So far, 29 patients with relapsed refractory mantle cell lymphoma had received Glofitamab, and in particular, 3 patients received Glofitamab at fixed dosing after 1,000 milligram Obinutuzumab. 7 patients received Glofitamab step-up dosing after 1,000 milligrams Obinutuzumab, and 19 patients received Glofitamab step-up dosing after 2,000 milligrams Obinutuzumab. The median age in this patient population was 69 years, with 83% of the patients having stage 3-4 disease. Patients were highly pretreated, and in fact they had received a median of 3 prior lines of therapy. 69% of them had been pretreated with BTK inhibitors, and 90% of the patients were refractory to any prior therapy. In terms of efficacy, overall, Glofitamab data resulted in a high response rate in patients with relapsed refractory mantle cell lymphoma. And in fact, the overall response rate in the 21 patients which were evaluable for efficacy was 81%, with 67% experiencing a complete metabolic response. Similar response rates were observed in patients who had received prior BTK inhibitors therapy versus patients who had not. Interestingly, 86% of the patients who achieved a complete response had ongoing remissions at the data cutoff. Safety could be evaluated in 29 patients, and this analysis showed that the most common adverse events were CRS, experienced by 59% of the patients, and infusion-related reactions, which were detected in 24% of the patients. All cytokine release syndromes were grade 1 or 2 by AST/CT criteria, except for 1 patient who experienced a grade 1 CRS. Interestingly, CRS rates were substantially lower in the cohort receiving 2,000 milligrams Obinutuzumab pretreatment plus step-up dosing. And in this cohort, the CRS rate was 47%, whereas the rate of CRS was 71% in the cohort receiving 1,000 milligrams Obinutuzumab, followed by step-up dosing Glofitamab. So in conclusion, we can say that glofitamab, used at a fixed duration treatment, demonstrated promising efficacy and favorable safety in relapsed refractory mantle cell lymphoma. Glofitamab at step-up dosing induced a high response rate in patients with relapsed refractory mantle cell lymphoma, most of whom had failed a prior BTK inhibitor therapy. CRS was manageable and mostly low-grade. Based on these considerations, glofitamab continues to be evaluated in the post-BTK inhibitors relapsed refractory mantle cell lymphoma setting, and these results will support a future confirmatory trial. Thank you for listening.